We'll discuss something about disconnection syndromes in the brain. That's also a vast topic. Some students have told that some of the presentations on neurology can never be completely dealt with. It is not possible. Only a template can be given because it takes several janmas to study. So this is a difficult topic. I try to simplify them. So we will see that. So we will approach this why that split brain is having different functions, because there is asymmetry in the brain. And but they are all connected by data linking circuits. Brain function is not uniform everywhere. Different regional domains are there. But they are all functioning together by data linking circuits. When they are disconnected, there's like a principal is there, and or unit chief is there, students are there. Each one of them have different positions, different functions, but they work together. When there is a disconnection, differential execution of function will take place. So they are the disconnections, and split brain is cutting the corpus callosum when the two halves of the brain are totally separated. So that is what I will do as a, this is mainly for DM students. Only the template I am giving. Anybody wanting clarification can ask. But as I said, neurology is very, very vast. A simple template will help the students to build upon that. So we know that there was an era of diagram makers. Diagram makers means they said that in the 17th, 18th century, one region of the brain has got one function. That is the era of diagram makers. But when those diagrams were not fitting in postmortem to clinical syndromes in all cases, then people said, no, these diagram makers were wrong. It is a whole brain is working together. Then that is the era of lumbers. Now we know that there are diagrams, there are lumping, and they are linked by data linking circuits. So currently we talk about data linking circuits and domains rather than regions. So Franz Gall, a late 18th century German anatomist, proposed localized different functions for different regions. That was the diagram maker. This was reinforced by Paul Broca, and then later the Wernicke's, where there's Carl Wernicke. He's described the Wernicke's area. Then you got Gratiolet, who identified left hemisphere matures earlier than the right hemisphere. And Geschwind and Levitsky in 1968, they found that left sylvian fissure is larger than the right one. So some kind of asymmetries were described by various people from the beginning of the 18th century. And right hemisphere is slightly larger and heavier than the specific gravity of the left hemisphere is more. Even though the right hemisphere is slightly larger, specific gravity of the left is more as more gray. So white matter is more in the right hemisphere, gray matter is more in the left hemisphere, and right hemisphere is larger and heavier, left hemisphere is smaller and less heavier. And thalamus, the lateral posterior nucleus of the thalamus is larger on the left side. And the medial geniculate body is larger on the right side. So these are some asymmetries. And primary auditory cortex, that's a Heschel's gyrus. It is larger on the right side. Heschel's gyrus is part of the language area on the dominant side, that is the left side. But it is larger on the right side. And why it is larger on the right side? It is having a role in the musical function. And music is processed entirely different from the way the routine words are processed. I have published some literature on this area. So because the music is processed by the right Heschel's gyrus, it is larger than the left Heschel's gyrus. And the temporal cortex is larger on the right side. And it integrates the spatial characteristics of sensory stimuli. And Broca's area, the visible surface is about 1/3 larger on the right side. The visible surface, that's the unfolded surface. Unfolded Broca's area is larger on the right side. But the buried Broca's area is larger on the left side. Burying increases the surface area. So visible area of the Broca's area is larger on the right side, but the Broca's area as such is not larger on the right side because the buried and the infolded ones is larger on the left side. And we usually try to find out language and hemispheric localization by looking at the handedness. So we have seen that so many areas are not symmetrical on both sides and they have specific functions for that. And grossly to assess which area is having language is the way we study asymmetry at the bedside. So 90% of the individuals are right-handed in the society and rest only are left-handed. And to study what is the dominant hand, we use the Edinburgh's handedness inventory. That contains about 10 questions, of which 8 is with whichever hand is the dominant hand. And it yields the laterality quotient ranging from -100 for extreme left-handedness to +100 for extreme right-handedness. So each one is coded depending on the various activities, which is done with the left, which is done with the right. So like that, at the bedside, we decide language is where, music is where, spatial orientation where, verbal orientation where, that kind of thing. And cerebral organization in left-handers, 70% of the left-handers have language representation in the left hemisphere. So it is ipsy hemispheric and 15% in the right hemispheres and 15% bilaterally. So even left-handers, majority of them have the language only on the left side, like the normal population. And 15% only is on the right side and 15% bilaterally. Cognitive functions are more bilaterally organized in left-handers. And aphasia occurs more commonly in left-handed because language is bihemispheric, but recovery from aphasia is more rapid and complete. Again, because the language areas on both sides. So even though aphasia occurs on either hemispheric lesion in left-handers, recovery is also faster. So here we see one picture. You can see that this person, the objects are kept on the left side and that belongs to the right hemisphere. So you ask him, what do you see? And he says he sees nothing because the vocalizing hemisphere is not seeing because it is separated. But you can see that he is seeing as evidenced by the left hemisphere, left hand trying to locate the objects. So even though the patient says, I see nothing, because the vocalizing brain is the left side, which is disconnected. But the seeing brain is the right side, which is seeing and manipulating. So when there is a differential functioning, separate functioning of each hemisphere, the verbal hemisphere will not acknowledge objects which are seen. And it will say, I see nothing. But the non-verbal hemisphere will definitely be seeing. That's for spatial localization. Non-verbal hemisphere or the right hemisphere is for spatial localization. So it knows, it localizes, it identifies, it touches, it manipulates, but it cannot vocalize. So it cannot say that I am seeing. So the vocalization component, so we will think, is it a psychiatric problem? He is manipulating, he is opening, trying to eat the banana, but he is saying he is not seeing anything. So that is split brain functions. And whereas if the left hemisphere is there and you keep an object on the corresponding side of the left hemisphere, that is on the right side, patient will say, I see an orange. So you tell the person, take that orange with your left hand. That he will not do because the spatial localization of the orange is not there because the right hemisphere is disconnected. So the verbal hemisphere will identify and name the object on its corresponding hemisphere. Non-verbal hemisphere will manipulate the objects on its corresponding hemisphere, but both does not happen when the brain is split. So this is emotion identification. So which half is smiling? Right hemisphere is to identify emotions and left hemisphere is to identify other features. So this similar test, identifying emotions is possible in the field where the right hemisphere is corresponding. Whereas identifying the features and naming them is possible if the object is on the field of the vocalizing hemisphere. So this is called Chimeric figure test, a behavioral test that measures how lateralized a person's cognitive processing is. The test involves presenting participants with chimeric faces, which are composite of two halves of a face that display different emotions. And participants are then asked to indicate which face looks happier. Next is the VADAS test. That is again like the handedness inventory, which is purely bedside questionnaire based. And you have got the chimeric test that will say by the naming or manipulating. And now you have got the Vada-Milner test. So patient is awake with outstretched hands and counting. And amytal sodium is injected into the carotid. 96% of the right-handers and 70% of the left-handers show speech disturbance after amytal injection into the left hemisphere. So that says that even 70% of the left-handers have their language on the left hemisphere. So this is another test to know the hemispheric localization. And this is induced by Wada and Rasmussen in 1960. And so this is no more done now because it is an invasive test. We have got better equipment, so it's no more done now. So then stimulation studies in conscious patient. So stimulating various areas and see what is happening. When you stimulate a motor area, the movement will come. When you stimulate a sensory area, patient will experience sensation. When you stimulate auditory or visual area, patient will have auditory and visual information. Then you know this area is processing this particular function. That is live stimulation studies. Usually started by Penfield. And stimulation causes responses also like deja vu, dreaming state, fear. That means the old memories are also brought out by stimulation. And left frontal or temporal regions accelerate production of speech. Stimulation can also block. So stimulating an area can either exaggerate the function of that area or block the function of that area. Both can happen. So that is the third, live stimulation studies. First is by the questionnaire, handedness inventory. Next is by the keeping objects in the field of the left hemisphere and trying to name and trying to localize, or vice versa. Then you have got the amytal test. Then you have live stimulation. Then you have got functional neuroimaging. That is cortical blood flow measures. Xenon 133 gas clearance technique will show the amount of blood flowing into the actively functioning area of the brain. And you have got you have got a positron emission tomography and functional MRI, where each task can be given, and at that time, which part of the brain is maximally metabolically active will point to the function of that area. Then you have got EEG. EEG, we know that the relaxing hemisphere will have better formed alpha. So left hemisphere will have poorly formed alpha and right hemisphere will have better formed alpha. So that is one method using EEG. And you can do the evoked potential and transcranial magnetic stimulation. These are the ways by which we demonstrate the differential regional functioning of the different parts of the brain. So this is regional asymmetry. That's the part one, asymmetry in the brain function and how we study that. Next is the disconnection syndromes. So inter or intra-hemispheric disconnection. So it can be between one hemisphere and the other hemisphere, or it could be within the regions of the same hemisphere in the various parts of the brain. This gives idea about functional organization of the brain. And so disconnections will produce definite disorders that will help us to know which part is disconnected, what happens. And Wernicke is aphasia is disconnection of the sensory speech area from the motor speech area. So he receives the information, but he cannot process and communicate. And he communicates in his own way with the paraphasic errors and fluent speech with poor modulation. And Digerin, 1892, described alexia without agraphia. I will be describing this subsequently. And Liebman in 1900, pure word deafness. And Liebman also described the various apraxias. And disconnections of primary receptive area from the other areas. So will produce. So one is disconnection of primary receptive area. What is primary receptive area? Visual primary is occipital. Auditory primary is Heschel's. And primary is parietal lobe. So the primary receptive area can be separated from the association area by large lesions. That is one kind of disconnection. So association area and the primary area disconnection. Association areas have qualifying effect on the primary vision. For example, your light and darkness colors, they are qualified beautiful color. Or this is the color which I wanted to see. That kind of adjectives and adverbs added to the primary sensation is the function of the association area. And next is the lesions of the white matter connecting association area. So one, the disconnections can be due to primary sensory area getting disconnected from the association area. Second is white matter connecting the association areas to other areas can be disconnected. Then your primary association area itself disconnected from the rest of the brain. So, and secondary association area that is somatosensory association area. Then you got tertiary association area respond to more than one sensory modality, that is polymodal association areas. So all this, you have got a primary area where the specific sensation goes and it gets modified in the corresponding association area. From the corresponding association area, polymodally associated in the inferior parietal lobe. I have previously done a talk on agnosia where I have elaborated this. What this means is, supposing you see a cat. The cat has got a tail which is furry. It is having 4 legs. It is having ears which stand out. And it is, so that is seen in the primary area. And it makes a sound which is meow meow. That is seen in the auditory area. And it runs around your compound when some food material is processed. And so it has got a sound, it has got a behavior, and it has got a color. All these are together polymodally associated in the inferior parietal area. So primary association area registers the primary information. Then the association areas qualify them. This is my cat, or this is a beautiful cat, that kind of thing. And polymodal association areas combine visual, auditory, tactile, limbic functions and puts them in a whole. So even emotions, when you hear, remember the words in which your mother would have called you once, then you can recall all the whole scenery and recall the picture of your mother. Or you just feel her sorry, you recall everything else, because these are all polymodally associated and integrated into a single information where my mother feels like this, she talks like this, and she loves me like this, she makes me this kind of good food. So anything related to that particular person is introduced, the whole picture can be withdrawn. That is polymodal association. Then you have got other connecting fibers, the white matter fibers, projecting fibers convey impulses to and from the cortex. And association fibers interconnect various regions, for which you have got short association fibers, that is connecting the adjacent gyri, and long association fibers which connect whole hemisphere. So anterior, you have got a longitudinal fiber from the frontal lobe to the occipital lobe. That is a long association fiber. And you have got uncinate fasciculus, orbit of frontal gyri to the anterior temporal lobe. That is the uncinate fasciculus. And arcuate fasciculus, superior and middle frontal gyri to the temporal lobe. And upper parts extend caudally to the parietal and occipital lobe. And so these are long association fibers connect several areas. Short association fibers connect neighborhood areas. And cingulum connects the medial part of the frontal and parietal lobes to parahippocampal and adjacent temporal cortical regions. So these are the various long and short association fibers. Then we have got commissural fibers. The commissural fibers, major one is the corpus callosum. It has got an anterior body which is motor, posterior body which is somatosensory, and an isthmus which is auditory, and splenium which is visual. Anterior is motor, posterior is somatosensory, and an isthmus is auditory, and splenium is visual. And anterior commissure interconnects olfactory bulbs and middle and inferior temporal gyrus. So corpus callosum is the major commissural fibers. Others are the anterior commissure and the posterior commissure. Anterior commissure interconnects the olfactory bulb and middle and inferior temporal gyrus. So we have got, so these are the associations. So hemispheric asymmetries in function we went through. Then how these hemispheres and regions are connected by subcortical white matter, gray matter, short and long association fibers and commissural fibers. And when these are disconnected, what happens? So disconnection causes aphasic syndromes commonly. So within the language network, isolating specific projection regions from the language network. So it can be two. So it can be within the language network. That is Broca's area is there, Wernicke's area is there, arcuate fasciculus is there. So these, each one of them may be disconnected, or isolating specific projection regions from the language network to the para-sylvian regions. So it can be that way. I have done a session on language before, the language alone. So that will, I have here, the aim is split brain, so I have condensed everything. So next, so it can be pure Broca's aphasia, pure Wernicke's aphasia, conduction aphasia, where there is disconnection within the perisylvian area. And its projection regions will be parasylvian aphasia. They are called transcortical aphasias. So next is alexia without agraphia. You see, inability to read is alexia. Alexia can be with agraphia. You can have agraphia without alexia, and you can have alexia without agraphia. Alexia without agraphia is unable to read, but you can write. So this was first described callosal disconnection syndrome. This is the first described callosal disconnection syndrome, because the lesion is on the left side. So patient with alexia having a lesion on the left side has right homonymous hemianopia. As all of us know that left parieto-occipital lesion will produce right homonymous hemianopia. So that is there. But his seeing area is now only the left field. Because there is a lesion on the left side and there is right homonymous hemianopia, he cannot get information from the right homonymous field. He gets information only from the left homonymous field. And the left homonymous field goes where? It goes to the right parieto-occipital region. Right is a non-verbal hemisphere. So this cannot read aloud, and comprehension from written words is lost, because the seeing field of a person with a left parieto-occipital dysfunction is not connected to the vocalizing hemisphere. It is connected to the non-vocalizing right parieto-occipital region. So left parieto-occipital and splenium, and new lesion on left angular gyrus. So this person, reading is a language function. He sees on the area which goes to the non-language part of the brain, that is the right parieto-occipital. So he cannot read. Reading is a language function, so he cannot read. So this is the pathomechanism of alexia without agraphia. Left parieto-occipital region is associated with the right homonymous hemianopia. So that particular patient's seeing area is the left hemifield, and the left hemifield goes to the right parieto-occipital region. Right parieto-occipital region is not the vocalizing part of the brain. So reading is a language function. So this person cannot read. So this is pure alexia without agraphia. Disconnection of the right visual cortex from the left angular gyrus in a patient whose left visual cortex has been destroyed. The angular gyrus is there, so he has no agraphia. So that is alexia without agraphia. So left occipital lesion produces right homonymous hemianopia. He perceives only from the left field, that is right occipital, which cannot read. This has to be transferred to the left, which is lost because of the involvement of the posterior splenium. That is why he is having alexia. Angular gyrus is intact on the left side, so he has no agraphia. So this is a classical disconnection syndrome, which was first time described. Then you have got pure word deafness. So only words. Patient,
angular gyrus is for the
he can hear
reading.
He can hear music. He can hear other sounds, but only the words he cannot hear. That is pure word deafness. So loss of auditory words, only words. Pure tones and non-verbal noises are intact. So auditory information does not reach the language area. So loss of auditory words. So other sounds are all understood. Why? Because the auditory information for words is not reaching the language area. This can happen in bilateral lesions, preventing Wernicke's area, which is receiving the words, from inputs of the Heschel's gyrus. So Heschel's gyrus is the auditory area. The comprehending auditory area is the Wernicke's area. If these two are disconnected, the heard words will not be recognized. So disconnection between the Heschel's gyrus and the Wernicke's area on the left side will result in pure word deafness. And unilateral subcortically in left temporal lobe involving left auditory radiation, callosal fibers from the opposite audit. This also will produce pure word deafness. So if the auditory information for words means it is on the dominant hemisphere, is not able to reach the vocalizing hemisphere, that is vocalizing region, that is the Wernicke's area. So if there is a disconnection in the cortical or the subcortical region, from the Heschel's gyrus to the Wernicke's area, you get pure word deafness. Then you have got conduction aphasia, where the arcuate fasciculus, you have got the Broca's area. These things I have done in the language presentation some 3 years back. So because there I did only language. It is done 3 years back. So conduction aphasia is Broca's and the Wernicke's area are there, but the arcuate fasciculus is damaged. So these people have Wernicke's area normal, so they are fluent, but it is disconnected. So some paraphasic errors will be there, and severely impaired repetition because the arcuate fasciculus is gone. Repetition is severely impaired. So apparently he is talking, and you tell him to repeat some few words that he will not be able to repeat. And the ability to repeat polysyllabic numbers is preserved. So he may not be able to repeat words, but strangely these people repeat numbers. They have intact comprehension because Wernicke's area is there. Naming and reading may be impaired. And lesion is because these two are disconnected. So even expression will have dysarthric element, grammatic defect, but they are fairly fluent because these two, Wernicke's and the Broca's area is intact actually. The connecting area is damaged. Connecting area's function is repetition. So severely affected repetition and relatively preserved expression and comprehension. So Wernicke's hypothesis involves connections between Broca's and Wernicke's area running in insula. And lesion of the arcuate fasciculus connects posterior superior temporal lobe to the frontal lobe. So this frontal area has the Broca's area, temporal area has got the Wernicke's area. This arcuate fasciculus connects these two, that is damaged. So lesion of the left temporal region with preserved comprehension. So because the Wernicke's area is there, so comprehension is good. But there will be errors because it is not working in a team. Speech is, Broca's area is there, but there can be some grammatical error, dysarthric error is again not connected. But repetition is severely impaired. That is conduction aphasia. And we have got a reverse, well-preserved repetition. Reverse of conduction aphasia, well-preserved repetition, and also automatic repetition. They may be going on repeating by themselves, and they have global aphasia. So this is disconnection of the perisylvian area from the rest of the hemisphere. So this is called isolation of the speech area. So if you have a severe cholera or an acute MI where there is hypotension, the perisylvian and the parasylvian area gets disconnected. The only function of the perisylvian area is repetition. So these people have parrot speech. They keep on repeating and they do not connect with the rest of the brain. So other information processing is not taking place. That is reverse of conduction aphasia, where preserved repetition and other functions are not there. Then you have got transcortical aphasia. That is motor transcortical aphasia and sensory transcortical aphasia. So motor transcortical aphasia is Broca's area is disconnected from the Broca's association area. It will resemble Broca's aphasia, but repetition is normal. Sensory aphasia is Wernicke's area disconnected from the Wernicke's association area. So patient will speak like a Wernicke's patient, but his repetition will also be normal. So these are transcortical disconnection syndromes. Then you have got tactile anomia. So inability to name objects by touch, but preserved by visual auditory mode. So this is a touch-specific failure of naming. That is called tactile anomia. First described by Geschwind and Kaplan in patient with a frontal lobe glioma. So failure of the somesthetic stimulation to cross to the left hemisphere and reach the language area. So when you touches an object, it This is a sensation. And this sensation has to go to the left hemisphere and then only he can speak it out. So if this crossing is impaired, the sensation perceived through any limb, right or the left, has to reach the language area. If it is not reaching the language area, patient cannot identify or name an object. He can identify, but he cannot name an object with the name an object which is touch. Callosal lesions will prevent somastatic information from the right hemisphere reaching the language area on the left side. So when there is a callosal lesion and patient has touched an object, this information has touched it with the left hand, let us imagine, that goes to the right hemisphere. He has touched it with the left hand, straight away goes to the right hemisphere. From the right hemisphere, the information has to be sent to the left hemisphere so that he can say what I am touching is a pen. So when he does with the left hand, it goes straight to the right hemisphere. From the right hemisphere, to speak out what he is touching, it should go to the left side. That is the language area. So that disconnection, whatever he touches, he will not be able to name. So he is not able to name objects placed in the left hand correctly. Naming of the objects in the left hand. But he is able to handle it correctly. Only the language is lost. Because I think understood, because the left hemispheric information goes to the right side and language comes from the left side. So from the right side, the information has to be transferred to the left language area so that he can speak out the name. That is disconnected. Patients, when blindfolded, able to select a correct object visually and tactually by the left hand. And if held in the right hand, can draw it correctly with his left hand. So if they are normally, when blindfolded also, when the hemispheres are connecting, they can do the activity by hemispherically. But when they are not blindfolded also, they cannot name when the hemispheres are disconnected. So next is apraxia. As you know, language and praxis are functions of the dominant hemisphere. So apraxia is defined as inability to correctly perform a skilled movement not caused by sensory, motor, cognitive or cerebellar disease on command. It is language link. So praxis is language link. It is done in detail in a previous separate session which I have done only on apraxia. I have done a session on apraxia that we can refer, because in this topic I just make a passing mention only. Next is the agnosia. Agnosia also I have done a specific separate independent topic on agnosia. I have done it. That can be revised. So agnosia is modality specific failure of recognition. So percept through a sense organ is stripped of its meaning. So he sees something, but he cannot get the meaning out of that, even though the end organs are normal. It is again done in detail in a separate session. Already it is there. Next, we will come to the corpus callosum. So what we saw now is intra-hemispheric disconnection. Now it is inter-hemispheric disconnection. So corpus callosum is divided from before backwards into 4 parts. That is the rostrum, then the genu, then the trunk of the corpus callosum and splenium of the corpus callosum. Its main function is to integrate and transfer information from both cerebral hemispheres to process sensory, motor and high-level cognitive signals. So whatever is received on the right side is transferred to the left side so that the language area processes it into language information. The corpus callosum is topographically organized and involved in the transfer of visual, auditory and somatosensory information in posterior regions, and higher cognition is anterior. So anterior callosal fibers transfer motor information between the frontal lobes, and posterior fibers are involved in processing of somatosensory, auditory and visual cues by connecting the parietal, temporal and occipital lobes. So anterior is motor, middle part is to memory and posterior is sensory. So causes of the split brain, it can be congenital corpus callosum abnormality, or it can be surgical splitting for epilepsy surgery. It can be mass lesions like gliomatous cerebri. It can be infarcts like vascular causes. It can be due to demyelination, tumors, or alcoholism, that is Markey-Faba Bignami's disease, and other causes like hemorrhage. So therapeutic lesions, the split brain operation in humans was first reported in the early 1940 by the neurosurgeons von Wegener and Heron as a treatment for intractable epilepsy, palliative treatment for intractable epilepsy. And they found that post-commissurotomy, patients were mute for some time, and this mutism lasted for varying periods of time, and the exact cause of this mutism is not known. Following corpus callosum sectioning for refractory seizures, they are observed to be mute. It is supposed to be due to diascisis or associated involvement of the cingulate gyrus, resulting in a cingulate mutism. So if the corpus callosum lesion disconnects the fibers from the cingulum, it can be a cingulate mute. So role of right hemisphere after callosotomy. So slowly the right hemisphere will learn. After the callosotomy, the right hemisphere learns to vocalize something. So receptive vocabulary can increase with the help of the right hemisphere taking over the language function. And single word comprehension can be achieved and not able to achieve full speech. So right hemisphere learns some degree of language after callosotomy. And memory after callosotomy, impairment of short-term memory is common and it might improve slowly following a callosal surgery. And exchange of memory engrams between the hemispheres is affected because what is seen on the left hemifield as an apple goes to the right side. This is polymodally associated. This is having a round shape. It is a reddish or whatever color it is, and it is grows in the trees. And this information is transferred to the language area, and then you call it as an apple. So this exchange of memory engrams between the hemispheres is affected, resulting in memory problem. And extracommissural language also contributes to the memory problem, like associated hippocampus, which is nearby, getting affected. So why memory impairment in corpus callosum? Bihemispheric transfer of information for polymodal association is not there. Second, there may be damage to extracommissural region contributing to the loss of memory. So what is hemispheric specialization? Left hemisphere is for language, speech production, semantic organization, self-recognition, problem solving, and causal reasoning. Right hemisphere is for spatial processing, perception, accurate memory recall, facial recognition, belief updating, perceptual reasoning. And shared ones is word recognition, object recognition, voluntary behavior, memory formation, and memory retrieval. So we will come to agenesis of that first we saw surgical lesion. What happens? Now we will come to agenesis. Usually patients with agenesis of the corpus callosum may not show major signs, may have impaired bimanual manipulation and coordination. And anterior commissure may be doing the most functions of people who have got congenital absence of corpus callosum. So anterior commissure takes over the function of the corpus callosum in people who have congenitally absent corpus callosum. So they do not suffer much function dysfunction, except when we test them, you might find some problem in bimanual handling of objects. So this is a patient. Here we can see that the corpus callosum is, you can see that you are not seeing the corpus callosum is not at all seen. This part, you are not seeing the corpus callosum, and here you can see that it is not really, this is septum pellucidum and corpus callosum is not seen. So corpus callosum agent is the most common brain malformation observed in humans, and it is estimated prevalence is 3 to 7 per 1,000 births. And this is, you can see, posterior corpus, anterior corpus callosum is there, posterior corpus callosum is not there, and there is associated Dandy-Walker cyst. And here you got both hemispheres are lying separate because the corpus callosum is not there. This is seen in trisomy 8. You also see it in Aicardi syndrome. So both hemisphere ventricles are separated because corpus callosum is not there. Then in congenital defects of corpus callosum, brain reorganization happens. It is congenitally absent. So brain reorganizes its functions due to neural plasticity, activating compensatory mechanisms, causing bilateral representations, and therefore deficits are less and capable of intra and interhemispheric transfer, but it happens slowly. By neural plasticity and activating compensatory mechanisms, the interhemispheric function is carried out, but it is slow. No major signs of disconnection is found in these patients, and some cases may have impaired bimanual manipulation and coordination, and anterior commissure takes over most of the functions when the corpus callosum is congenitally absent. So you can see a bleed in the corpus callosum. This is a bleed in the, this happens in diffuse axonal injury, in head injuries. So anterior corpus callosum is having motor functions. It will result in left arm apraxia. And here you can see an infarct, and this is a gliotic area, and this is a tumor. So oligodendroglioma with anterior corpus callosal extension. Demyelinating disorder. So you can see the demyelinating plot. So what are acute disconnection syndromes? These are chronic, congenital ones, tumors, demyelinations, they are all chronic. Acute disconnection syndrome, one is surgical, and corpus callosum lesion in left hemisphere dominant patient. So if the person is having language on the left side, following corpus callosum lesion, there is mutism, there is mild akinesia, and competitive movements between the two hands. That is intermanual conflict. So patient who is left hemispheric dominant following corpus callosum lesion becomes mute and shows intermanual conflict. Whatever one hand tries to do, the opposite hand will oppose. Then repetitive grasping or groping with the left hand and left arm hypotonia and left-sided apraxia to verbal commands. So that is called left arm apraxia because movement schema for the left hand is processed in the right side. So this information is not crossing when the anterior corpus callosum is damaged. So the person has left arm apraxia. You tell, you raise your left hand. So patient is not able to do it properly because the information processed in the perisylvian area has to cross over to the right side, get the motor schema and activate the left side. That disconnection results in left arm apraxia. Left hand behaves like a foreigner and they are surprised at purposeful left hand actions. So it will act mostly like a hand which is autonomous, not obeying the commands, but sometimes it does purposeful activities. Then chronic disconnection syndromes are categorized into 4. One is social ordinariness. Second is loss of interhemispheric transfer of information, hemispheric specialization effect, and compensatory behaviors. These are the 4 features of chronic disconnection. Social ordinariness. So special testing only may show the problem. Otherwise, socially, they look normal. So the chronic disconnection syndromes, we saw that there is compensatory reorganization of function in the brain. Second, the anterior commissure takes over the function of the corpus callosum. So there is the phenomenon of social ordinariness. So apparently they look normal, and only when you do the special test, you might identify the defect. Second is loss of interhemispheric transfer of information. So they are unable to retrieve with one hand an object which has been placed, palpated by the other hand. So we saw the people who can manipulate with the left hand an object which is kept in the left field, but he cannot name it. So he can manipulate with the left hand, he cannot name it because the 2 hemispheres are disconnected. The language area cannot retrieve the language even though he identifies the object. That is loss of interhemispheric transfer. The first phenomena is social ordinariness. Second phenomena is loss of interhemispheric transfer of information and hemispheric specialization effect. So right-handers will not be able to name or describe an object in the left hand. So left hand object goes to the right hemisphere. So it has to be transferred to the language area on the left side to be named. So it will not happen. So right-hander will name it if the object is on the right hand. But if the object is on the left hand, he cannot name it. Then compensatory behavior. A number of strategies like the patient speaks loudly the name of the object being palpated on the right hand. And as the right hemisphere can recognize many words, the object, because we saw that during recovery, the right hemisphere learns the left hemispheric function and right hemisphere becomes altruistic. It sacrifices its function and learns the left hemispheric function. So by reading loud, it tries to reinforce the right hemisphere, it learns. So chronic thing will be social ordinariness, loss of interhemispheric transfer of information, and hemispheric specialization effect, and compensatory behavior so that some of the functions recover. Then lateralization procedures. Nobel laureate Roger and Sperry and Michael Gazzaniga discovered that split brain patients can only respond to stimuli in the right visual field with their right hand and vice versa. So supposing you have an object in the right field, with the right hand, he can localize that. With the left hand, he cannot. With the left hand, he can localize on the left hemisphere. But with the right hand, he cannot localize on the left field. So testing with the visual stimuli usually involves presentation of stimuli to each of the visual hemifield for a duration of less than 200 milliseconds, brief enough to preclude a saccade towards the stimulus while it is displayed. Each hemifield projects to the contralateral visual cortex, and thus a stimulus on the left hemifield will be seen by the right hemisphere. So right hemifield object is identified by the right hand. Left hemifield object is identified by the left hand. An object in the left hand, a left hemifield, you tell the person to pick it up with the right hand, he cannot. An object in the right hemifield, you tell the patient to pick up with the left hand, he cannot, because interhemispheric transfer is not there. This is called double hemianopia. So hemianopia for the right field for the left hand, and hemianopia for the left field for the right hand. So in order to achieve lateralized presentation of stimuli, patients have to fixate on a central point. Stimuli are displayed at locations eccentric to the foveated point by several degrees of visual angle. So it should be put on the eccentric region, and a chin rest is often used to minimize head movement, and infrared tracking can ensure that the patient's gaze remains on the fixation point. And using the brief presentation technique, simple pictures, words, shapes, and colors can be lateralized. It should not come to the central field. So this is the sliding hemifield defect and double hemianopia. So double hemianopia patients have two floating fields which they slide. So in the sliding area, objects become polyopic. Then partial lesions, section of the splenium and mid-body disrupts transmission of visual and somatosensory information between the hemispheres. So this is visuosensory. So usually it is color anomia. So patient cannot name colors. They can point to the color when named and they can match color, but they cannot name colors. And intact anterior pathways transfer semantic information between the hemispheres. So patients perform better on test naming on the left visual field stimuli, although performance is often slow and imprecise. So intact anterior pathways, that's anterior commissure, that produces some recovery even in patients with the visual field stimuli on the side which is non-verbal. And anterior sections produces left arm apraxia, and anterior mid-body tracts affect bimanual coordination for complex motions. So you have got the right hemisphere stimulus and left hemisphere stimulus, and it has been shown that posterior disconnecting surgery prevents the transfer of information related to sensory. I told color anomia. So it's a visual sensation. Sensory dimensions of the stimulus, but not the semantic. So the meaning is there. That is why he can match. He cannot name the color, but he can match the color. The result was consistent with the overall knowledge that more anterior regions of the callosum are committed to the transfer of higher order information, especially motor, and posterior sensory. During bilateral movements, steps include initiation of movement and transfer to the opposite hemisphere informing each hemisphere of the output from the other and regulating feedback process based on the sensory information. This is called positive cortical tropism, causing phenomena of agency. So what I mean, this is meant for the DM students, as I say. What I mean here is, supposing I am moving my right hand. A command has been received to move my right hand. When I move my right hand, the sensory information is continuously sent back, saying that I am moving my right hand. So you have told the person to move the right hand. He has moved it, and the moved right hand gives information back, saying I have moved. That is called a positive. Supposing the principal tells you to do something, you do it, and then go and tell the principal, I have done it. So the principal will know this particular candidate did this. So the principal will tell my college student did it. That is called phenomena of agency. So only if the information is sent back to the brain that this has been carried out, the brain will take agency for that act. So if this is not happening, the brain will not take agency. So that so it will not know that one hand is acting according to his command. That results in strange hand phenomena. So that body part which does not give information to the corresponding sensory cortex by the phenomena of positive cortical tropism will not be owned by, like a student who does something and goes to tells a principal, I have done it. That student will be projected by the principal, this boy did it. If somebody does it but does not go and tell, then the principal will not know. So he will not say, this particular candidate is also from my college and he did it. So that will be automatic. So that part of the function will not be recognized by the brain. So coordinated hand movements require proximal and distal movements for reaching and grabbing object, thus requiring interaction between the ipsilateral and contralateral hemisphere and an intact corpus callosum. So colossotomized patients can thus show antagonistic activity of the hands, which can result in intermanual conflict. So intermanual conflict is because each hemisphere is not working in coordination. So each one is becoming automatic when the hemisphere is disconnected. Then what is the fate of objects and words presented in the center of the visual field? Why it does not create a challenge in split brain function? So what is kept in the center, even when the split brain is there, is sometimes processed. So it is assumed that foveal information is sent in parallel to the left and the right brain half, and as fovea is bilaterally represented and overlap. So each one can independently process as it is bilaterally represented. And interhemispheric transfer is fast enough that it does not limit the interhemispheric communication in a noticeable way. And this is hypothesis. Foveal area is bilaterally represented, so each one can independently recognize. That is the main hypothesis. This person also, I have shown the video also in the apraxia talk. This is a diagnostic apraxia. So this was a girl initially when she was reading, her book is being pushed down by the left hand. So she thought, people thought it is some devil, something and all. So when she's eating also, the plate will be pushed out by the left hand. Those videos are there in my apraxia talk. So she was taken for all magical activities. Finally, psychiatrist later came to the neurologist and we found this lesion. And this is diagnostic apraxia. Whatever a patient does with one hand is not because of the lack of intermanual coordination, the opposite hand will independently come and block this. So this person later learned to sit on her left hand so that it does not prevent the action of the right hand. So this video is there in my apraxia presentation. Next, we will come to face processing. The right hemisphere shows greater ability than the left hemisphere in matching pictures of similar faces. Yeah, that is visual, spatial, sensory. So right hemisphere has greater ability to match. Left hemisphere is better able to voluntarily produce facial expressions of different emotions. So left hemisphere recognizes and able to voluntarily produce facial expressions of different emotions, whereas right hemisphere is able to match similar faces better. And memory, have poor memory for new information such as word association, because it is polymodal association that forms the memory. As I said, if your mother is there, she has got an affect, she has got a speech, she has got a feel, and she has got a height, weight, beauty. So everything together polymodally becomes a memory. This polymodal association needs bihemispheric information, because visuospatial information is on the right side, verbal information is on the left side, limbic information is the subcortical limbic area, and this is polymodally processed in the inferior parietal lobe. So if this is not there, the memory information is incomplete. This results from interaction of both the corpus callosum and hippocampal commissure and fornix. Recognition memory may not be affected to the same degree as recall memory. So they may just recognize, but they may not be able to recall. Left hemisphere has got poor performance on tasks that involve distinguishing between previously seen and novel items with semantic content, such as words or pictorial representation of common scenes. So left hemisphere language and semantics. So those have semantic contents. When there is a left hemispheric lesion, the performance is poor. Left falsely recognize previously unseen items that were semantically congruent with items shown during the encoding phase. So it might misidentify similar features and wrongly recognize objects when it is damaged. So callosal disconnection, anterior pathology, tactile anomia. So through the touch, it cannot name. And apraxias, and copying defect, dyscalculia, and alien hand. And posterior pathology, left tactile and visual anomia, sympathetic apraxia, left arm apraxia, color anomia, and double hemianopia. Then you have got defects in alien hand. Alien hand video is also there in the apraxia talk. So in alien hand patients, you have got frontal alien hand, callosal alien hand, and sensory alien hand. Among all the alien hand, only the frontal can be right or left. All other alien hands are only left. And frontal alien hand manifests as grasp, compulsory manipulation, and groping. And we have had one patient who was standing in the queue in the railway station, and he had a frontal alien hand. It was putting his hand into the nearby person's pocket and manipulating. But patient does not know, it's an alien hand. So somebody will think he is trying to do pickpocket. So that is frontal alien hand, grasp, compulsory manipulation, and groping into the neighborhood without conscious awareness of what the frontal lobe is doing. And second unique feature is frontal is both right or left. Both hands. All other alien hands are only for the left hand. Then callosal intermanual conflict. So what the right will do, the left will oppose, like the diagnostic apraxia. Lesion is in the corpus callosum, more towards the non-dominant side. Sensory is levitation, keeping the hand in odd position. This is typically seen in corticobasal degenerations. So this is grossly, I have given a template on what is the hemisphere asymmetry in function, what are intra-hemispheric disconnections, grossly only the template, and what is this inter-hemispheric disconnection. So take-home information in commissural disconnections, congenital callosal lesions do not produce typical defects. Most defects are objective than subjective. So subjectively, rest of the brain has rewired, taken over the function, anterior commission takes over function of corpus callosum. So patient may not have complained. You see the MRI and then do the test, you might find something. Clumsiness and slowness is more common than major defects. Left arm apraxia, sympathetic apraxia, failure to match objects and names across both fields, mild memory problems, color anomia, double hemianopia are seen in the rostrocaudal plane. And subcortical transfers play a role in recovery over a time. Over a period of time, right hemisphere will recover and subcortical tracts will establish connection and they recover. And right hemisphere learns over time.